I take the privilege of inviting Dr. Rajeev Agarwal Garu onto Fertility Committee member from 2008 to 11 and 2023, member Andrology Committee, ISAR, Joint Organizing Secretary for ISAR 2018. He had more contributions towards academics, and he's the Director for Renew Healthcare Kolkata and International Fertility Academy. Now, Sir will be delivering lecture on...
Good afternoon, distinguished chairpersons, delegates, and the outside people, sometimes even on stage. The common thread is that IUI pregnancies don't happen. It's really a waste of time. It's very frustrating to have patients coming back again and again. I, in fact, had a discussion with a senior business development officer of one of the IVF chains in Kolkata. And he said, we don't promote IUI at all. Really, it doesn't work. So, and after doing 2 to 3 cycles of IUI, these patients tend to go away. So we directly talk about IVF. I think today is a time to understand why these people are wrong. IUI definitely works. And there is a lot of benefit in doing an IUI, which we'll try and understand in the next 30 minutes. In 2013, NICE came out with guidelines which said, IUI is trash, do not work with IUIs. It had certain reasons to do so, and G. Bahadur et al., a very prominent andrologist in UK, wrote this letter to the editor, wherein he said that you've based your entire guidelines on the article of one Bhattacharya et al., which I think is wrong. Bhattacharya et al. Had a pregnancy rate of 6% in that article, wherein the national average of IUI for UK that year was 13%. One of the things which the article said also was that multiple pregnancy rates is very high. In that article, they had wrongly taken clinical pregnancy rates as the endpoint and not live birth. And we all know that not all twin pregnancies which are confirmed land up as twin pregnancies when they deliver. There is a spontaneous reduction which happens. The next question which G. Bahadur et al. Asked was, we do transfer 2 to 3 embryos during IVF, and we do create, or we ideally try and create 2 to 3 embryos, 2 to 3 follicles in an IUI. Then how come transferring those 2 to 3 embryos in IVF does not land up with all twins and triplet pregnancies, and we're talking about 2 or 3 follicles in an IUI creating twins and triplets? Lastly, G. Bahadur et al. Also presented his own data, wherein he achieved a pregnancy of 20.1% per cycle, such that 39% of women less than 35 years old actually getting pregnant, speaking volumes about the benefit of IUI. The next year, someone did a study and asked all the fertility clinics across UK, saying, look, NICE has come out with guidelines and says IUI is not to be done. So what is it that you people are following? 70% of the clinics responded and said that 96% of them are still doing IUIs, speaking volumes about the wrong message that NICE guidelines were putting out. This is a very nice article which came on 2018. It said that live birth was 31% with IUI, and that the cost of doing an IVF was 2 to 3 times higher than doing an IUI, which we all know, and that 20% of couples who would otherwise have to do an IVF got pregnant with IUI itself. Why is the success rate of IUI so bad? Of course, we'll be looking at a lot of other things, but we always look at the West and say, the West must be doing the right things. And this is a very interesting article which was done based on a Netherlands study, wherein they tried collecting data from all the IVF specialists, laboratories, on how they do IUI. And the heterogeneity was absolutely crazy. So much so that if you see, only 25 or 50% of the clinics were actually looking at morphology as being important. And we know that morphology is one of the most important parameters to look in a semen analysis. And there was considerable heterogeneity. This is, of course, a very busy slide, but just to show you that there was disparity in everything that they did. Obviously, it's going to result in probably low IUI percentages for a lot of clinics. Dr. Jyoti Budi and Ferty9 hasn't reached here, obviously, in one day. She's put in years of hard work, small little stepping stones, every day putting in their hard work. And that's how you get success. And that's how we need to look at IUI success as well. So we need to look at a good evaluation, a good selection, a good workup of that couple, good ovarian stimulation, monitoring, semen preparation, IUI, and a post-IUI management. Every single step has to be taken and looked into carefully to ultimately achieve an IUI success. Patient selection. Maternal age becomes one of the most important things which you look at when selecting a patient for IUI. And if you see here, the pregnancy rates for a woman less than 30 years of age has much higher pregnancy rates as compared to someone who is aged higher than 30. And the pregnancy rates continue to drop. And understand that this is a study with Caucasian women. And I don't know how many of you are aware that the ovarian reserve is 6 years different or higher, or rather 6 years lower in Asian women as compared to Caucasian women. So here they might still even consider IUI for someone who's 40 years old. But in the Indian and Asian scenario, someone above 35 would obviously or already have their ovarian reserves lower. When we come into the factors which decide or which patients you would put into IUI or expect a higher IUI success outcome, you see male infertility gives you a lower pregnancy rate as compared to a female infertility. Within the female infertility itself, ovulation disorders give you about 19%. As Dr. Purva has also spoken, if you work up your PCOS patients well, the pregnancy rates and the ultimate satisfaction you get after looking at these patients is brilliant, and the pregnancy rates, even with IUI, will be much higher. The success rates with unexplained infertility are obviously the lowest, also because what we knew as unexplained only are defects and problems that we've yet not discovered. And that is why the pregnancy rates are lower in these cases. You've already selected your patients. Now you need to do a workup of these patients before you take them up for IUI. Good clinical practice would say never do an IUI without doing a tubal patency test. As simple as it may sound, I'm sure a lot of you would have seen prescriptions where the patient has undergone IUIs without doing a tubal patency. In my opinion, the only place where you could probably do one single IUI without doing a tubal patency is a complete male factor infertility, azoospermia. You could probably try doing one cycle of IUI. Why is tubal factor test important even in an azoospermia case? Is because we know that spontaneous pregnancies also increase merely by flushing the tubes when you do a tubal patency test. And thus, even for a case of azoospermia, you might actually improve the pregnancy rates when you do a tubal patency. Now you've already done 3 cycles of IUI, you want to take this patient up for maybe 1 or 2 more cycles of IUI. You might want to consider doing a laparoscopy to look at the peritoneal factors, endometriosis, because we know that a lot of these things are not picked up in your regular tubal patency test. Semen parameters for success. Initial sperm count should be more than 10 million. Initial sperm motility should be more than 30%. Post-wash, so maybe you want to go a little further and say, will this patient do well? And there's so much of count and motility and morphology and everything else which is coming in. Just do a wash. And if you find that the post-wash 100% motility is more than 1 million, you could probably subject this patient to an IUI. Now, this is again something that I've been using in my practice all through, that once you've done your semen preparation, before insemination, leave a small little bit in that test tube and tell your embryologist to incubate it for the next 24 hours. See the sample the next day. Usually 70% of those sperms should survive. Morphology, if there is one thing that you're going to look in your semen analysis before subjecting the patient to an IUI, it should probably be the morphology should be more than 4%. We've always spoken of the age of women. More and more studies are now coming in saying the paternal age is also important. As this slide shows, if the male age is more than 35, the duration of infertility is more than 3 years, a high DFI, or were all poor prognostic factors. I remember having discussions with an andrologist at the beginning of my career when there was just talk of DFI starting. And he had said, DFI is absolutely humbug. There's nothing you can do about it, so why bother even talking about DFI? Today you ask an IVF specialist, and we are all doing DFI in our practice regularly. Can you use DNA fragmentation to also decide if you'll subject this patient to an IUI? You can. Most of us would be looking at a cutoff of 20 to 25%. If it is more than that, the patient would probably do better with an IVF. than with an IUI. This article tells you that probably the threshold should be even lower. A 10% cutoff should probably do better. Someone who has a DFI of less than 10% will have a higher pregnancy rate as compared to someone who has more than 10%. So we've always been taught as surgeons that, what to do, how to do a surgery, what are the correct steps, and so on and so forth. But the hallmark of a good surgeon also will be to know what not to do. Similarly, in the case of an IUI, in a stage 3 and stage 4 endometriosis, do not subject this patient to an IUI. Very poor sperm parameters, again, it's not going to work. Age more than 39 years, probably in the Indian or the Asian scenario, such patients will do much better with an IVF. But this is, of course, about counseling. This is not an absolute term to be taken as something written in stone, something that you need to discuss with your patients. And of course, continuing IUI beyond 4 to 6 cycles probably is not cost-benefit effective. The only place, and we've all been speaking about using gonadotrophins and more injections will give you more pregnancies. The only place that probably less is more is if you have mild semen parameter problems, and that is why you're doing an IUI, because they're creating more follicles, will divide your sperms between all these follicles and probably reduce your pregnancy rates. So if you have mild male factor defects and you're doing an IUI, reduce your stimulation. Probably using only a letrozole or clomiphene will do. In unexplained infertility, it is very, very important, and I think all of us have reiterated that ovarian stimulation is very important. Maximizing the number of quality oocytes is the single most important factor for success. And ask yourself, have you not seen prescriptions, or some of you even may have done it yourself, just given letrozole or a clomiphene and subjected the patient to an IUI? Those patients are going to have a very, very low success rate, as we're going to see the numbers in a while. Pregnancy rates with 3 follicles is about 37%, with 2 follicles is 26%, and with 1 follicle, which is what we are going to achieve mostly with the letrozole, is only 7.6%. It does not justify the cost of an IUI. Beyond 3 follicles, the pregnancy rates don't increase. The multiple pregnancy rates might be higher. Ovarian hyperstimulation may happen in rare cases, so it's best not done. And when gonadotrophins are used, it must be on a daily basis. Now, this is something that I was kind of smiling when Dr. Jyoti Buddhi said, I'm not using gonadotrophins on a daily basis. Please understand the difference from her to me. When she's saying I'm not using it daily, she means from day 2, right probably till ovulation, like we do in an IVF cycle. When I'm saying we use it daily, it is in a sequential form, as Dr. Apurva and Dr. Jyoti said. Use your oral ovulogens first from day 2 to day 5 or day 6. After that, add gonadotrophins. Don't do it like a day 2, day 4, day 6, and day 8. It doesn't work. When you add, you have to add on a daily basis. Now, when you do an ovarian stimulation, clomiphene alone, as I said before, only gives you a low pregnancy rate. When you combine the 2 oral ovulogens with your gonadotrophins, it gives you about a 12 to 13% success. If you use gonadotrophins alone from day 2, right for 10 days to 12 days, you will get not only 19%, we've even had 25-30%. But whether you would like to do that or switch them to an IVF is a call that you have to take. Downregulation, again, Dr. Jyoti Buddhi has already said, downregulation doesn't work. Most studies have shown that IUI does not require an endogenist usage unless you're using a daily injection protocol, you have multiple follicles developed. In those cases, use of an antagonist may be justified. Does size matter? Of course, in an IUI, size matters. So normally we've been told that give your ovulation trigger when the follicle is about 17 to 18 millimeter size. Does it hold true for all cases? So if you're using oral ovulogens, probably it makes sense to take your follicles to a slightly higher size of 20 or even 21 before you consider giving your HCG trigger. But when you're using a lot of gonadotrophins, probably you can bring the size down to a 17 or 18 millimeters before you give your HCG trigger. Is size the only important thing that you're going to look at? No. Again, we know now that Doppler is very, very important in deciding when you're going to give your HCG trigger. If you do nothing else, if you just look at the perifollicular flow, if you get a 75% halo, along with everything else being in the right place, you know that this is a good dominant follicle, and your chance of achieving a pregnancy is on the higher side. Some recommendations from ESHRE 2018. What is the best timing of insemination? And after the HCG is given, an IUI done between 24 to 40 hours, usually at 36 hours, will give you a good pregnancy rate. An IUI done probably before ovulation would have more success than an IUI done much after ovulation has already occurred. When a patient comes to us for an IUI and the patient goes to the andrologist or the embryologist for a semen collection, you don't even get a call saying the patient has come and the semen preparation is happening. You receive the call only after the sample is probably ready. You already have 3 patients lined up, you're probably running late for that particular day, and they keep calling from there and you keep saying, I'll just come, another 10 minutes, another 15 minutes. Does that matter? Again, we go back to what we had said initially. Every small little stepping stone, every step that you take is going to be a building block towards your IUI success. So maintaining a very short interval from semen collection to semen wash, that is about 30 minutes. From sperm wash to IUI, usually the best thing is to do it immediately. And from semen collection to the final process of doing an IUI should ideally be less than 90 minutes. If you try and maintain that, you will find your IUI successes to be higher. Semen preparation, Charu has already spoken volumes on that. I don't want to get into it. What we need to understand is, as far as IUI is concerned, they've shown that no one particular method is superior to the other method. Whatever works for you and your laboratory is good enough. IUI catheter, again, this article shows that whether you use a soft one or a hard one probably doesn't make a difference as long as it works for you and you don't create a trauma. But from common sense and practical purposes, a soft catheter would probably cause less trauma than a hard one. Catheter toxicity, this is again something that I don't know how many of you practicing IUI would be doing, but we lay a lot of focus on the consumables when IVF is concerned. But as far as IUI is concerned, probably some vendor walking into your clinic and saying, madam, this catheter is only for 20 rupees, the one you're using is for 40 rupees, and you would say, I'm saving 20 rupees, let's use this catheter. You can, provided you do a sperm survival on every single consumable that you use in your lab. So the semen preparation that you had made, and you realize that it survives for 70%, the 70% of it survive, leave a small bit of it in your catheter for 24 hours and leave it in your incubator. The sperms should survive the next day. And if your consumable that you're using, if that catheter that you're using has sperm surviving inside it, it's a catheter which is good to use. Steps of IUI, if you see this picture, we've always been told one of the first things we were taught, and I have my teacher, Sujata madam, sitting here as well, that empty the bladder. Any procedure that you do as a gynecologist, and probably all of us would have failed our PG exams if we did not say empty the bladder in the first case. For an IUI and a lot many procedures today, we say, please don't empty the bladder, and you will see why. So if you see this bladder is only half full, the catheter is trying to enter, the uterus is antiverted, and the catheter invariably hits the posterior wall of the uterus, you'll keep struggling, you'll get frustrated, there'll be a lot of bleeding as well, and you will not achieve a good pregnancy out of this. Before getting into your IUI, before actually loading the semen sample, what is it additionally that you can do to increase your pregnancy rates? Some studies have shown that washing that catheter with some media would actually improve your pregnancy rates as well, because it would kind of balance the pH inside the catheter. Here you see the bladder is optimally full. We know that the uterus is now pushed back because of the overfilled or properly filled bladder. And you will see that the catheter is gliding in far more smooth. And these are just those basic 50 rupee catheters that we all use, and without any trauma to the patient, making it very, very easy. Steps of IUI, patient position, it can be a lithotomy or a dorsal position. Cervix position should be midline. You'll realize there's sometimes just a simple cough can make things so easy for you. It can put your cervix absolutely in the midline. Sometimes if you're not being able to negotiate the catheter, keep the catheter at the internal os inside the cervix and ask the patient to cough, and you'll see pop the os opens up and your catheter will glide in that very moment when the patient makes a cough. Clean the cervix. The nurse must confirm the patient identity. Load the catheter. And of course, check the mark of the catheter for anteverted. You would want to know if the uterus is anteverted or retroverted and guide your catheter accordingly. Importance of the guard. Now you will see that there is a small little guard which is there on the catheter. Most of these guards are fixed in such a way that your catheter will just go beyond the internal os and not hit the fundus. We all know that we don't want to touch and hit the fundus because the uterus is going to contract and throw whatever you're going to put inside the uterus, whether it is going to be a processed semen sample or your embryo for an IVF. So these guards are, kind of in the right position. Introduce your catheter inside, keep the guard there so that the flux of the semen sample or the processed sperm does not come back from the external os. Hold it there for a few seconds and then you can withdraw your catheter very gently. Sperm survival testing I've already spoken to you about in a few minutes ago. Fallopian tube sperm perfusion. Now, obviously when everyone is trying to improve their pregnancy rates, a lot of studies said that one of the reasons why in unexplained infertility, pregnancies don't happen is because the amount of sperms you're putting in is not good enough. Normally, we put about 0.5 ml of inseminate. These studies said that put about 4 ml, flush the tube with sperms, and you will find your pregnancy rates going up. Of course, the latest studies have shown that the 4 ml of flushing of the tubes is not good enough. But G. Bahadur et al., and you can go and look this up, came up with a very interesting talk. And I think it holds water because he said, when you take only 0.5 ml of inseminate, a lot of it actually remains inside your catheter. And what goes inside the uterus may not actually be 0.5 ml. So he said, why not start taking 1 ml of inseminate? That would leave some amount in your catheter, and the rest of it then would go inside your uterus and improve your pregnancy rates. Point to think about. Does the use of ultrasound help IUI pregnancy rates? We all use ultrasound for doing our embryo transfers. Some of these studies have shown that if you use an ultrasound guidance, and most of the clinics would have an ultrasound in their clinics, and if you place the sperms in a proper manner, in a proper place, the pregnancy rates go up. However, there are many other studies which have said that there is no benefit of using an ultrasound. Difficult IUI, we all experience difficulty while doing an IUI. One of the most important things to think at that point in time is be patient. You can use an Ali's forceps to gently pull the cervix. Remember, if you're very harsh with pulling your external os, the fundus will contract and will throw the semen sample out. Check the bladder. As I've said before, I explained why the bladder becomes important. Use an ultrasound guidance if possible. Ask for a cough reflex. Wait for some time and try again. Sometimes fatigue sets in. You get upset, you get angry, and you want to force the catheter inside. Just wait for some time. Maybe have a cup of coffee, let the patient rest, come back and try again. Use a uterine sound. Sometimes a uterine sound can just create that right passage, and then your catheter moves in very smoothly. If nothing works, make the patient head down, and you can probably do an intracervical insemination and let the gravity allow the sperms to move inside the uterus. Of course, if you've had trouble in this particular cycle, make notes of it and see what you can do in the next cycle to make at least the next cycle IUI much better. Maybe doing a cervical dilatation on day 7, day 8, day 9 would make sense because the cervix actually remains open and makes it easier for you to do the IUI the next time. Intercourse avoided or forbidden. It has been shown that obviously, again, common sense, if someone has a low sperm count, adding a natural intercourse to it would improve the pregnancy rates. But does it help for unexplained and other kinds of indications where you do an IUI? Yes, it does. Doing an intercourse probably even the day before you do an IUI, because we know that semen sample remains in the cervical mucus fold and stays there for about 72 hours. So you would have an extra amount of sperms being present even if you've gone wrong with your IUI timing. What is the optimal number of inseminations per cycle? Most studies have shown that doing an IUI just one time in that cycle is good enough. 2 IUIs do not make sense. I personally like to do 2 IUIs when I do a more aggressive stimulation and we have 3 to 4 follicles present at that time. But most studies, of course, have shown only single IUI is good enough. Is there a benefit of bed rest after IUI? A 10 to 15 minutes of lying down after doing an IUI definitely optimizes your IUI success. What is the ultimate number of consecutive IUI cycles that you should be performing? Some studies have said that you cannot really define how many IUIs need to be done, but from a cost-benefit ratio, doing an IUI after 4 to 6 cycles of IUI does not give your patient any extra benefit. Luteal phase support, I know we all give it. Most studies have also shown that doing some sort of luteal support after an IUI would make sense. Newer concepts, I of course read about it. I didn't even understand it. I asked a couple of my colleagues, they've never heard about it. But elastography is something which some people are doing via ultrasound, and they're saying the more stiff the uterus, the more the pregnancy rates. This is again something interesting. Now, when we do an embryo transfer, we are very careful about the uterus not contracting. We even give maybe injectable progesterones on that day. We give some other drugs as well to make the uterus more quiet. How come we don't think about the same when doing an IUI? In my practice, we give a piroxicam tablet on the day of embryo transfer before taking up the patient for an embryo transfer. This article says that piroxicam can be used in IUI as well. Of course, they've used it 4 to 5 days after doing an IUI, but my logic would make more sense to probably give the piroxicam on the day of IUI at least, if not after. There are various websites today. If you go there, they will be, if you feed in the patient data, they will give you the success rate arising out of an IVF cycle. Unfortunately, we don't have such a robust system for IUI, but there are a lot of people nowadays who are working with algorithms for IUI. Probably in the years to come, we would be having such robust algorithms wherein even before we start work, we can tell a patient what the success rate would be for that particular patient out of an IUI. To summarize, IUI is definitely a good modality of treatment provided you use it well. Having a gun is no good unless you know how to fire it properly. Gonadotrophin stimulation is a must if you want good success. Use Doppler for deciding the day of trigger. Use good practice guidelines like doing a tubal patency test. Last but not the least, you must know when to stop and convert to IVF. Thank you so much for a patient hearing.